Hello, I'm Neil Spooner, the chair of the Patient-Centric Sampling Interest Group, and welcome to our first webinar of 2025. Who can believe we're already on the 15th of January? Anyway, welcome to our event, and hopefully you'll be registering for many more to come throughout the year. I'd like to introduce our first speaker of 2025, Vincent Molinar, who's a PhD candidate at Leiden University and also works with Greiner Bio 1. Vincent's going to be talking to us today about unlocking the future of blood collection, a step-by-step guide for the performance assessment of capillary sampling methods. But before Vincent starts, I'd just like to thank our sponsors who enable these events to happen. Thank you to all of you who attend these events as well. And a lot of you are now viewing our webinars on through our website and through our YouTube channel. So please take a look if you haven't looked there already for previous content. So today, Vincent's going to be talking to us. This event is being recorded, so it will be available through our website and through our YouTube channel probably next week. If you have questions, please submit them through the chat. Hopefully there'll be plenty of time at the end of the webinar to go through your questions. And with no further ado, I'd like to hand over to Vincent. Good luck, Vincent, and I'll see you at the other side.
Okay, thank you, Neil. And thank you also, PCSIG, for this opportunity for me to present on the quality aspects of patient-centric sampling. So as said, my name is Vincent. I am affiliated with the Leiden University Medical Center here in the Netherlands for my PhD on accessible at-home blood sampling. And next to this, I work for Greiner Bio 1 in the global team as the global market manager for alternative sampling. And right now I'm calling from the Netherlands because that's indeed where I live. So I used to work in the international innovation team for a very big European laboratory group. And this is where I acquired a lot of skills on shifting blood collection from the clinic to the patient's home and to make it more patient-centric, including all the challenges that come along with it, so shifting towards someone's home. So I'm here today because I'm very passionate about making blood collection easier and more patient-centric. And so today, therefore, this webinar will be about sampling method-induced imprecision, a new concept that I would like to introduce to this community because it's very important for microsampling products. And why is it important? That's what I'll explain, what it is and how we can actually measure it to do something about it. Because this phenomenon can be easily underestimated right now, and it's very important. If you have any questions during this presentation, feel free to drop them already in the chat during this talk, and then after that we will have the Q&A session so we can touch upon those. Let me see the slides. Yes, it seems to be working. Okay, how this webinar will be set up. I would like to start first off by saying that the contents of this webinar are all based on a scientific paper I co-authored. And this paper will soon be published in the Clinica Chimica Acta. So once online, I will also post this on my LinkedIn. So feel free to connect with me to be notified when this paper is published, because I expect it to be roughly published officially within 1 week or so. It's right now in the pre-proof phase, so it's almost finished. We will start. I think I have enabled pointer. Yes, we will start then by explaining the why we are talking about microsampling now today, what it is that's driving it, and we will touch upon some of the advancements made already in microsampling because there are a lot. And then dive a little bit deeper into the matrix effects of capillary samples, because this is very important to understand before we move on to the S3 methodology. This is a new methodology that I worked on together with the team, part of my PhD, and it's based on Six Sigma, which is known from Westgard also, and we'll touch upon it later. And then I will go into the use case. So we tested this methodology using a use case. And the overall goal for today's webinar is to show the effects of imprecision by the sampling method. And we will do that using a couple of polls also. So an explanation along the way. So the reason why we're talking about this. The why is very important as we're talking about microsampling at home. And that's the reason for this topic of the webinar. So let's zoom out a little bit and look at venipuncture. Venipuncture has been the same for decades, for a long time, while patients actually did change over the years. And they expect easier access to healthcare, better availability of it, like 24/7 access. And I'm actually also one of those patients that expect easier access to, for example, blood sampling and actionable insights that can be usually or actually used to improve your health, all from the comfort of your home. And these important trends, how you could call them, are driving healthcare shifts from the clinic towards the home. And people are looking to take control over their health, have access to actionable health insights via testing facilities available online. And of course, I also know that there's this debate around availability of online laboratory testing, at home testing, but it does tell us an important sign that there's growing demand for it. And I think it's also, as laboratory professionals in this field, in the microsampling fields, it's also our call on us to provide healthcare at home responsibly. And while all the technology advances, it provides opportunities for remote monitoring, remote sampling, maybe even remote treatment and remote diagnostics of patients using digital healthcare. We could use digital healthcare tools as a means to reach this end. Here on the right side of the slide, you can see next to all those changing demands, there is also more macroeconomics. So there's the burden of healthcare provisions right now. So this was, of course, a major challenge during COVID, but the challenge continues to grow with the staffing shortages, rising healthcare expenditure, and increasing diagnostics needs from all the different changing demographics. So because life expectancy is growing globally, and so does the prevalence of chronic diseases, this all translates into more diagnostic needs. And how can we all still facilitate and these needs without the staffing shortages, for example? Because of all these macroeconomic trends, research recently, or over the last couple of years, has also focused on how we can empower patients to take control of their own clinical care and provide them with remote treatment and monitoring strategies. And I want to specifically mention now here that to keep care accessible and affordable now and in the long term, I really believe that microsampling innovations are needed. Or to make it even broader, I would say shifting healthcare from clinic to home is needed to answer some of those demands. So if we look at some of the future of blood collection, technological advancements, because there's already a lot. Because of all these trends I just explained, recent technological advancements have led to more and more devices available, whether or not commercially available or for research use only. The picture here presented on this slide is an excellent overview from Dennis in Poland and the colleagues that from his recent review in the CCLM. And as you can see, it shows multiple technologies, sometimes based on upper arm or finger. But these technologies are either based on liquid collection or dried collection. And depending on the exact use case or the need for specific analytes, you can use liquid or dried blood. And the idea behind these devices is to, so to say, empower the patients to perform self-sampling of blood at home. But still, I think this is important to realize, while some of these devices are commercially available, there is no mass adoption of these microsampling solutions yet. And they build actually upon a a standard or a paradigm of venous blood collection. But here on the next slide, I really believe that capillary sampling is not the same as venous sampling, and you can our human body is actually very beautifully designed, and with it comes the blood. So this blood serves a certain function, and of course, oxygen exchange, energy exchange. And while the blood travels through our body, there is the differences in oxygen levels, glucose levels in your blood. And because of this sample type is already different, and most of our knowledge is based on the venous blood collection right now. And the microsampling is challenging this knowledge base. We are essentially thinking or talking about a new way, even though capillary sampling, of course, has been around for some time, but the microsampling solutions that are entering now are different. And therefore, I think we cannot really transfer knowledge of venous sampling one-on-one to capillary sampling. So, for example, the composition of blood, like I just mentioned, in capillary is different. And there are also effects that occur in the sampling process of capillary blood. And together, these are affecting clinical use or utility for the microsampling. Now, I want to fire up first off with the poll, and let me see if I will enable it. It should work for everyone. Otherwise, please give a shout. The poll will be, can triglycerides be validated based on this passing and Bablock regression? And while you do that, I will explain a little bit more on what do we see here. So what we see here is a combination of capillary results from the TAP2 device in this case. And this you can see on the vertical axis here. And on the horizontal axis, you can see venous results. And those dots that you can see here, all over here, they represent patients. And what you can also see is that this red line is representing the statistic test that tries to find the best fit between the capillary method and the venous method. So if we, for example, look at one particular patient, this is how you usually read it. For venous blood, roughly he or she had a result of 1.5 for triglycerides from venous blood. But from capillary blood, this same patient had a result of 1 millimole per liter. And this is an important difference that we can find. Okay, let me see and look at the poll results. I think I have to click on end interaction fill just to be sure. Let me do that because I can already see the results, and the results are roughly 48% that would say yes, we can validate and use this analyte for clinical use. Some say no, 15%, and 36% say don't know. I will explain more on the exact what we see here on this triglyceride, and we'll later share the exact answer with you all. So what do we see? What's actually happening? Because this is very important to understand. What we just saw for triglycerides was an example of imprecision. Imprecision is a random error that can occur, especially in microsampling. And the downside of this imprecision is that you cannot correct it. And looking at this picture here, you have several situations. There are some more, but this is, let's start here. You can see, in general, the laboratory always aims to have no error, of course. So this means the test result is accurate and precise. Here, for the second example, you can see that this is accurate, but it's not precise. And you can see that by the clouds of dots. So this is more scattered, but it's still accurate. And this is an effect of imprecision. And sometimes this is also referred as variability of results. And that's what I wanted to mention, is that a very important property of imprecision is that it occurs on a random basis and you cannot predict it. So you can also therefore not correct it. Last example is more a systematic error, accuracy. So here you can see they're pretty precise, but they're not accurate. So they're not centered. So this is not the true value that you were looking for. The reason why I'm showing you this specific figure is because most of the laboratory professionals probably here already know and have seen this figure multiple times in different forms. And accuracy and precision is very important pillars for the lab. But when I was working in the IVD industry, we tested some of these microsampling devices also. And what we saw was exactly this imprecision problem or phenomenon. And of course, in the lab, this can occur from analyzers in the lab, and they will always have some form of imprecision. But the kind of magnitude that we found was so big that we had to look into this further. So I just want to mention that the key message for this slide is that there's exactly this random error of imprecision is more prevalent in microsampling. And this is what we consider, or I call in our paper, sampling method induced imprecision. And I will explain the components of what it's built upon in a moment. So this is also a very important reason to realize that sometimes I hear that maybe we have to adjust reference ranges for capillary blood, but if we're talking specifically about this imprecision or sampling method induced imprecision, this is very difficult because you cannot correct an effect that occurs on a random basis because you will never know how to correct it. Okay, just another way of showing it, imprecision in practice. This is more a theoretical example. So what if we test a single patient multiple times for HbA1c? And we do that with two different methods. So, for example, here on the left side, capillary, and on the right side, venous. And if you look at capillary, 43, 40, 42, 41, 39, and for venous, 41, 41, 40, 41, 42. Notice the variability or the imprecision among the results for the capillary versus the venous collection. And this is a very important reason why, for example, also the American Diabetes Association has cautioned the use of point-of-care testing for diagnosis of diabetes mellitus because of this variability. This does not always have to be an issue, this variability, but it may become an issue if you're around cutoff points for clinical decisions or diagnosing patients with diabetes. And this can also be very analyte specific. Okay, bear with me because this is maybe a little bit statistic and a little bit dry, but I will explain it as easy as possible. So this is a theoretical model that we created, and it's included in our paper, explaining exactly this variability effects of the sampling method specifically. So we're diving into a lot of detail. If you look at figure A, then you can see this is how we see the gold standard. This is venipuncture. You see a normal distribution like this, very normal distribution around the true value analyte. And the total imprecision, you can see that's the total width of this graph. There's always this imprecision that's always there. That's in this case mostly from the analyzers. And if you look at B, then we see all of a sudden that the graph shifts to the right. And this is called inaccuracy, or better known as bias. So It used to be around the center, and now it's moving to the right. Notice that the total imprecision, so the width of this graph, is not changing. If you go to example C, and this is very important, it becomes interesting because here we do not see a bias, so it's still centered around the true value, but the graph is greater in its width. So this means the total imprecision has increased. And this is exactly a very important representation of sampling method-induced imprecision. And I will explain how you can measure it exactly. And here, for D, it's the worst case scenario because you have both. So you have a bias, inaccuracy, and imprecision. So perhaps, but there's debate about this, you can correct for the bias, so shift it to the left again, but the imprecision is simply impossible to correct. And I think it's very important to realize for microsampling adoption that lab results need to be equivalent to central lab results and therefore fit for purpose. So let's look at some practical examples from our use case. So here you can see triglycerides, which we already looked at, but now in a different way. Here you can see blunt Altman plots. This is something probably very familiar to a lot of people here. But you can use this tool to estimate bias or inaccuracy and total precision of a specific analyte when comparing two methods. So here's a perfect example of sampling method-induced imprecision that's happening with microsampling technologies. And so let's break this graph a little bit down step by step. So here you can see this solid blue line. That is the mean of the finding. So the mean accuracy. So there's, in this case, it's 1.53. So there is some small bias, but not a lot. And the dot clouds, you can see all the way over here. That shows the amount of imprecision. And the broader this dot cloud becomes, the more imprecision there is. And this is a practical example from our use case from the figure I just explained, C. And because of this sampling method-induced imprecision, we could not validate the triglycerides for clinical use. And just another example, LDH. Here we had not accurate and not precise results. So here you can see the solid blue line is around the 25%. So there was a bias, and also the width we had increased imprecision. So this would be an example of D, the worst case scenario. Now looking at what's happening here over here. So why do we find this amount of variability for microsampling? And one reason, which I explained, is also the capillary matrix effect. So the composition of blood is different in capillary versus venous. For example, of course, maybe people know blood gases, they have different pH values from different types of blood. And glucose as well, because it's metabolized in the tissue. But also there are effects of shear forces that are introduced to the red blood cells or thrombocytes, or which is better known as hemolysis or thrombolysis. And then we have the variability of the sampling method. And this is, most people know, for example, the tissue squeezing when you're collecting a sample from your finger. You have to launch your finger, and then it's very difficult to collect the blood. So therefore, people start squeezing or milking the finger. And what's actually happening, in fact, is that you're damaging the cells, and you also push interstitial fluid, so the tissue fluid, into the sample, which results in essentially diluting the sample. And the same effect could happen for microsampling products that use vacuum, for example. So this is, I think, very important to this is known, and this is how can we measure exactly this effect. I think it's as a key takeaway for this is that it's really important to realize that blood is very fragile and it's a very delicate process to collect it. And especially with lower sample volumes in microsampling, this becomes a bigger issue if you're not collecting it on a very delicate way. So what did we do? We wanted to quantify exactly this effect that we found, the sampling method induced imprecision. Because we see in literature right now also that there's a lot of fragmentation in different validation methods, or this kind of imprecision sometimes is not included in papers. And therefore we developed the S3 methodology that included the sampling method induced imprecision. And it's based on Six Sigma method for laboratory medicine, developed some time ago already by Westgard. Here you can see this is the traditional approach where Six Sigma already combined accuracy and analytical precision or imprecision from the analyzers. And we know that the sampling method induced imprecision can affect the sample quality, and we wanted to measure it. And therefore, we wanted to combine both the sampling method induced imprecision concurrently with accuracy and analytical precision. So here you can see this becomes a little bit dry again, but bear with me. Traditional Six Sigma approach. So this is from Westgard in 2006. Here you can see the sigma, and this built upon several components. TEA, which is the total error allowable, which you can calculate from the excellent database from biological variation from the EFLM, for example. The bias, which would be an absolute bias, and the analytical variation, or the analytical imprecision of the analysis platform. And you also have another version if the total error allowable is not cannot be achieved, or this could be called, this is called the state-of-the-art criterion, which is the best technology can provide. Sometimes the analyzers cannot do a better job, and then you can take the state-of-the-art. So this is what we try to do. We try to include sampling method induced imprecision, the accuracy or bias, analytical imprecision, and the TEA, the total error allowable, all into one equation. And that's one you can find over here. Here you can see the new equation that we made for the S3 methodology. And I will explain it just because it's not too different, but what we did is I will not explain how we eventually got here, but what we did is we included now the sampling method induced imprecision for LUBC in this case, and LUBC is called, or stands for lateral upper arm blood collection. So these are some of the microsampling solutions from the upper arm, which are entering more and more introduced. And we derived this component, sampling method induced imprecision, from the total imprecision that we found from the Blunt-Altman plots. So this was just the plot that I showed with the blue line. And then eventually you will end up with an unambiguous sigma score. And we used, in that case, 3 as the industry standard for acceptable clinical performance. So depending on your application, maybe it's not to diagnose someone, or you have different applications, you can also decide to lower the sigma score to 2, for example. This is also common in some cases. Now, we tested this methodology in our use case. And here you can see this is what we did. So we compared the gold standard venipuncture against upper arm blood collection. We included in total 159 participants in this study, and there were 59 employees and 100 patients from outpatient centers. And we recruited them as part of their routine care. So we went through medical ethical committee and got approval, but we also did not analyze extra analytes. So If a specific analyte of interest to us was not on the order form of the blood collection for this specific patient, we did not analyze it due to ethical considerations. So eventually for the patient, it took them a little bit more time, no follow-up required, only one extra capillary sample from the upper arm that they could collect. Now, what we did, this is the way we analyzed the results. I hope everyone can read it, but I will explain it. You can see all the way on the top here that the sigma calculation was based first on the total error allowable, and if it was more than 3, then we verified and validated the analyte. If it was less than 3, we looked into the state-of-the-art criterion. If it was more than 3, it was verified. And if it was less than 3, it was non-verified analyte. So some of the results, which you can see here, is that not all analytes, that this is a selection. So we in total had 14 common clinical chemistry analytes. This is a selection of the analytes that I want to show. And here you can see this, the S3 scores, the sigma scores. For ALP, it was 4.7. So we passed validation on the first step of the total error allowable. But for some analytes, it was not possible. Here, for ALT, triglycerides, CRP, it was possible in the first step. For LDH, it was also not possible. So if you then look into the imprecision that we found, the total imprecision is very interesting to see. For example, triglycerides, the example of the poll, that a lot of imprecision eventually was caused by the sampling method. So in this case, 12.2% total imprecision was found altogether. And of that component, 12.1% was accounted to the sampling method imprecision. For CRP, this also occurred, but it was within the limits of total error allowable in this case. And for triglycerides, it was not within the limits of total error allowable, therefore resulting in not being able to use it for clinical use. And LDH, there is an example of a combination also with the sampling method induced imprecision being very high component of what we found from the total imprecision. For all the analytes of this use case, we found that 93% of the total imprecision found was caused by the sampling method induced imprecision. So this was a major effect that we found. And now that we know, there may be also possibilities to do something about this sampling method induced imprecision. But before that, I would like to go to the bias or the accuracy, because this is also a component of quality performance assessment. And here you can see we also found bias, but it was for some cases more, and for some other analytes it was less. I would like to point out also CRP. There was not a lot of bias, but mostly imprecision found. And for LDH is the example of a lot of bias and imprecision at the same time. If you look into the total analytes that we analyzed, you can see that we validated 5 analytes in total: ALP, bilirubin, HDL cholesterol, CRP, and sodium. And the other analytes we could not validate. And we hypothesized about reasons why we saw more effect of sampling method induced imprecision. And we found, or this needs to be tested, but that high intracellular concentrations of analytes seem to correlate with increased imprecision, but this again needs to be tested. And all the other non-validated analytes showed either inaccuracy or sampling method induced imprecision. rendering their results unsuitable for clinical use. So in turn, now that we have a better understanding of how big this effect is, it also aids in finding strategies to reduce sampling method-induced imprecision. It could be, for example, microneedles that are used with the TAP2 device versus Lancet. At least it seems to always turn down into shear forces that are introduced to the cells being collected. And this is important because eventually we need to attain clinically viable results for a patient, also in microsampling situations. Just to zoom out a little bit again before we end and go into the final poll. While those microsampling devices already exist, they are not widely used or remain sometimes less adopted. I think it's also important to realize that there is more to it than just a microsampling device. So digital sampling collection processes supporting this new idea, this new paradigm. And of course, we have the quality aspects, but also pre-analytical variables of logistics, time to analysis, temperature monitoring during logistics. We did look into some stability, but this was not considered in this paper, for example, now. This will only challenge the situation more. Technological development to reduce the sampling method-induced imprecision. Unit economics, of course, is also very important, and for insurance reimbursements. Regulatory, but also very important, I think, is usability. For the patients and laboratory professionals need to be involved in development of such solutions. Okay, final poll. I'm just curious. Let me see. Start. What do you think? Can we validate this analyte triglycerides based on passing and Bablock regression? Now, while we wait for the results, I want to mention that low imprecision can be deceiving when interpreting some passing and Bablock regression. And this was never a major issue to venipuncture, but as it's mostly affected by analytical imprecision, venipuncture, but for microsampling solutions, this is new, and the components of imprecision affecting the way we used to be interpreting those validation results. And let me see. So right now we have, I just ended the poll. 62% would say no, we cannot use it. And 30% would say yes, and 11% don't know. So exactly this random error is more prevalent in microsampling, and we should look into it more and do something about it, try to do something about it. For the take-home messages, I would say accuracy and analytical precision alone are not sufficient to assess agreement between two methods. And microsampling introduces, whether we like it or not, increased variability due to the sampling method-induced imprecision. And technological advancements are needed to reduce sampling method-induced imprecision. And S3 methodology can serve as an unambiguous comparability assessment of microsampling solutions. So it would be easier to compare and contrast several different microsampling products. And we could use it eventually to reduce the sampling method-induced imprecision. I just want to end with this slide with some acknowledgement to the very excellent team that how we created this paper. And also a shout out to the PCSIG, and also we'll be at the Liverpool conference coming soon. So if you're happy to connect, we'd love to connect over there. Let's go to the Q&A session. So I'll leave it here. Back to you, Neil.
Thank you, Vincent. Very interesting presentation. Thank you so much. So we're starting to get some questions coming in. Please send them in versus the chat function. Just going to go through the questions in the order that they've come in. So I've got a question here from Daniel. How do you differentiate / measure the sampling method induced imprecision and the total imprecision?
So how did we measure it? So we looked into, we made the Blunt-Altman plots. We tried to find the total imprecision. And then we said, okay, the total imprecision assumed is based on multiple components. The analytical precision from the capillary test on the platform, analytical imprecision of the venous test on the platform, and the sampling method induced imprecision. And then we did some mathematical changes to the formula, and that's how we eventually found the specific sampling method induced imprecision.
Okay, thank you. Next question is from Derek. Why are shear forces considered the largest driver of imprecision in this study?
What we see is that some of those intracellular components are found in the test results that we found. So because some of those analytes are more present intracellular and we are testing them in the sample, there is some sort of effect happening where some of those analytes are leaking into the sample. So that's why we consider it could be one of the important sources for imprecision here.
Yeah, understood, Vincent. Thank you. Next question is from Christian. Have you looked at effects of age on microsampling, differences between adults and pediatrics?
That's a very interesting question. The population that we studied now was 21 years of age and older. Pediatrics could be very interesting to look into as well, but we did not look into it, so we didn't study it.
Okay, thank you. Emily says she's got 3 questions, but I can only see one. So Emily, oh yeah, I see that further down. Okay, good. First question from Emily, we'll cover others later. Did you process these samples immediately? How many hours passed between collection and analysis?
Yes, because it was outpatient clinics, it was in the center of the Netherlands and city Utrecht. There are multiple locations scattered around the main central laboratory. We tried to do it as fast as possible, so I would say it was around 2 to 3 hours after collection that we did the analysis and centrifuged and everything. Yeah.
And do you know whether stability had been shown under those conditions already, Vincent?
Yes, they were validated because this is the business model of this specific laboratory. Yeah.
Thank you. Question from Floris. Is there a major difference in vacuum levels between vena tubes versus home sampling collection tubes?
Depending on, so sample volume in vacuum tubes or evacuated tubes for venipuncture, there's more volume, so vacuum level will be higher. For home collection tubes, they are not evacuated. So, for example, the Grinder Mini collection system, they are not evacuated. So there is a difference in vacuum level. I hope this answers the question.
I think so, yeah. Another question from Emily. Is pH of microsamples higher or lower than venous?
This is a very good question. So the CO2 level and in blood gases, I would definitely have to look up all the details again for how this worked again. I used to know it, but CO2 and the pH, whether or not it was up or down, I would definitely have to do a good look into it. So it's a very good question, Emily. I could come back to this if you want.
Okay, thank you. And second half of Emily's question, is glucose metabolism higher or is it just a greater concern due to smaller blood volumes?
I don't know if I completely understand, but if glucose metabolism is higher in capillary, what do you?
Yeah, I don't understand the question really. Maybe Emily, you want to put that question in, rephrase that question so we can understand it later. Keimer, what is the experience of users with the capillary sampling method? I think this is a really important question as well.
Yes, absolutely. Very good question also, because if you want to have adoption of microsampling solutions, this is a very important component. We did look into this as well. I did not include it in the paper because of lack of word count, but we did look into it, and we found similar results to literature already available. And we found that microsampling solutions were favored over venipuncture because patients could do it themselves, and they also experienced less pain during the collection process. So the user experiences were good, but they also showed that there were improvements needed. For example, the actuation button, the plunger of this device, was very difficult to activate for some of the patients. And this is very valuable information if you want to improve this kind of technology. So yes, this should be very much part of any future assessment.
Thank you, Vincent. Next question from Ricardo. What analytical platforms were used for the samples? From which whole blood or serum? So what analytical platforms were used for the samples, and from which whole blood or serum stroke plasma matrix?
Yes. Analytical platforms were Beckman AU for clinical chemistry, and from plasma, because we use lithium heparin. You might wonder HbA1c. What we did is we aliquoted for the LUBC, so the lateral upper arm blood collection. We aliquoted a whole blood sample before centrifugation and put it on a TOZO analyzer. The exact model I could share if you want. And for venous, we collected EDTA and lithium. So there was a small difference. It's a good question.
Okay. And Bradley, thank you for inserting a very good word into your question here. How does your method handle heteroscedastic data?
The way, so this is a phenomenon for regressions. We did, so for the Six Sigma, this is not a specific component that we looked into. So I don't know, Bradley.
Okay. Third question from Emily. We know refrigeration raises pH and slows down glucose metabolism in blood. Our team uses refrigerated shippers to increase stability. Where can we expect that to make the most impact? On imprecision or on bias?
Interesting question. I think it would affect mostly the bias, because when the refrigerating reduces the metabolism, and therefore less glucose is being used into the sample container. So I would say may improve mostly the bias, but we definitely have to look into maybe also imprecision. But I would for now say bias.
Okay, thank you. Question from Eric, which you may have covered with your previous answer. Which matrix did you use, plasma or serum tube, to compare?
Plasma.
Okay. So Emily's rephrased her question here, her glucose question. Is glucose metabolism a bigger concern in microsamples than venous? If so, is it because you're sampling on the arm deltoid muscle where glucose metabolism may be higher than in the crook of the arm where venous blood is collected?
So is it bigger concern maybe for microsamples than venous? I think we should also ask a clinical chemist here, because I'm also not a clinical chemist. So I would definitely want to refer this also to clinical chemist, I would say. Yeah, I don't know.
Okay. Emily says, thank you for answering my questions. If you've got any more questions, we've got a couple of minutes left before we wrap up here. So if there are any other questions, I know we've had a lot. some questions that were sent in before the event. Is your step-by-step guide for performance assessment informed from interaction with medical device regulators, e.g. FDA, etc.? And if so, what are the main performance metrics regulators are requiring?
So it was not performed or informed by regulatory bodies, but I think the other way around, it could definitely help in understanding the effects that are occurring in this sample microsampling, and maybe it could alter the regulatory approval eventually. But then I would definitely also ask other people to validate this method before we do so.
Yeah. An interesting question here. Are you aware of any technologies, hardware and or software, that improve test performance on capillary samples?
If you look into some of the effects that occur, like the random effects, I think software would be difficult to combat this kind of effect. Hardware, maybe it would be in the micro needles or a clean lancet that could affect the sample quality, because then maybe there's less damage to the cells and this effect would be smaller. So this could be a possible thing to test, a hypothesis to test, I would say.
So I guess building on that, Daniel's just said, can you think of any design improvements to current microsampling devices to reduce errors?
Yeah, so maybe the like I mentioned, the lancet or the microneedles, or the flow of the blood, if it's in contact with certain foreign objects, maybe it will influence this effect. This all needs to be tested.
Okay, so we're going to take this as I think the last question from Frederick. Do you believe that self-sampling will be part of future healthcare?
Yes, it will be part of future healthcare. It will definitely not replace existing venipuncture, for example, but it will be part of future healthcare because it serves a certain societal impact where people can use and then be empowered to take control over their own health. And therefore, I really think this is important for future healthcare. There are some challenges that first need to be overcome before a gold standard for microsampling can be set. One of them is this quality aspect, and there's more on the logistics and all the other things that I talked about. But yes, it will be part of future healthcare.
Thank you, Vincent. So I just want to wrap up with a couple of other notes. Just note for people that weren't here from the beginning, the webinar has been recorded and will be available on the PCSIG website and the PCSIG YouTube channel in the next few days, probably early next week. Just a note, we've got webinars actually booked up till February 2026 now, but the one for February 2025 is coming up on the 26th of February with Nithya, and she's going to be talking about perceptions and acceptability of microsampling for remote monitoring in patients with plasma cell dichrasis. So just for those of you that don't know much about the patient-centric sampling interest group, there's a little bit of information about it there. Those QR codes will take you either to our website or our LinkedIn group. The LinkedIn group is where we speak to each other. We're 500 members on that group. Some very active conversations and sharing of information. Website contains a lot of information on all of our webinars and all the content. And I'd finally like to thank all of our partners and sponsors, particularly the evidence base who give us the platform to do these webinars. And lastly, I'd like to thank you, Vincent, again for an absolutely fantastic webinar today. And I'd like to thank our audience with a phenomenal number of attendees, really good number of questions, really exciting and interesting questions. So thank you all, and look forward to seeing you all at our next webinar.
Thank you, Neil.